Good afternoon, everyone. We're going to talk about ultrasound in critical care today. So I know some of you have done the course, some of you haven't. So there will be some refreshing stuff, but then there will be some directed towards critical care and what we can do just to help us out. So I'm sure you're aware that POC stands for point of care ultrasound. And I think you still need to apply your brain. It doesn't help that you just wave the thing around. You must have a focused question. It doesn't help to not engage with it, because you need to interpret the stuff and be able to then come up with some type of diagnosis. But I think the main thing that I just want to state to you is that, we've been taught to take a history, examine the patient, do some side investigations, then come up with some type of diagnosis, then maybe some special investigations. But the point of care ultrasound is different. You should see it as an extension of your hands and your eyes and your ears. And it shouldn't be something you reach for, oh my goodness, I don't know what to do. It should be part of the exam because you need information. And you know as well as I is that examination can only take you so far. To get more information, you need to use an alternative device. And that's what the ultrasound's about. To be able to just see, is this because of something else? What am I missing here? Why is there free fluid? Why am I struggling with ventilation? All these things are things that with a clinical exam, it's actually quite difficult to know, especially in the ICU environment. The patient can't talk to you oftentimes. So this is where you need a little bit of extra tools. So we're going to run through it very quickly. So this is not a level 1 ultrasound course. Otherwise you'd have to pay. And you're getting coffee for free, so it can't work like that.
And CPD prints.
And CPD, this is true. So we're going to go EFAST and basic cardiac echo. We're going to talk about VEXUS. I don't know if any of you come across VEXUS. Quickly DVT, lung, vascular access, and then some practical applications. Okay, so EFAST, it is a binary question of is there free fluid, yes or no? Is there traumatic pneumothorax / hemothorax? And then the question is, can you quantify? And I think from a level 1 point of view, we're just asking a binary question. Is there free fluid, yes or no? But, as you scan more patients, you can have a very good idea about, listen, is this where the bleeding is coming from? So oftentimes we have a trauma patient and there is free fluid, but listen, it is like minimal. I need to really hunt for it. It is there. This is then not the cause of the shock. Does that make sense? So I think you've got to put things in context, but, it is difficult to quantify, is this like 500 mils, a liter and a half? We had ectopic pregnancy the other day. So that, and then look, if you put the probe there, it's in the right upper quadrant and everywhere. Look, it's going to be a liter and a half, probably. But yeah, so just keep in mind that it is really a binary question. Okay, so we're going to use the curvilinear probe. Quickly, subxiphoid, a left upper quadrant, pelvis, subxiphoid, and then we're going to interrogate the lung. And that can really help in the initial stages. So this should really be part of your primary survey. So as you go along, it is really difficult to listen to a pneumothorax when and there's alarms and it's really difficult to know, is there really or is there not? Is there decreased air entry? You're welcome to percuss your patients. Don't, knock yourself out. But, just put the probe on and just have a look. I think this is just so much quicker and simpler. Okay, so pericardial effusion is something, obviously we've got a question. Is there pericardial effusion, yes or no? And it isn't always that simple. So there is a bit of physiological fluid around the heart, and we do have some TB patients that also get stabbed, or some other patients that get stabbed. So you've got to put things in context. And that's why we see a small pericardial effusion, and we ask you guys to admit them if they stabbed, and we repeat it. But there is a little bit of fluid around there, but certainly more than a centimeter is pathological. So something definitely is wrong now, whether it be TB or blood, that is what you'll need to figure out. So we're quickly going to just run through the basic stuff just to remind you guys. So what are we going to look for? And luckily, eyeballing the EF is fine. That's good enough. You don't need to be able to do an EF. Gross chamber size is also relatively easy to see. Now, it's difficult for me because I do a lot of echo, so I'm saying it's easy, but if you haven't looked at a heart before, then maybe it's not going to be that easy. That's why the more you look at hearts, the more you'll see that is abnormal. So we're just going to say, look, is the LV dilated? Is the RV dilated? Is the RV bigger than LV? That gives you a lot of information. And the valve pathology is usually quite obvious if it's causing problems. A minor aortic stenosis or regurg is probably not the reason why the patient ended up in ICU. So the obvious stuff, like severe mitral stenosis or severe aortic stenosis, that is so easy to spot. Okay, but you need to put the probe on. And you're going to miss it with a stethoscope when there's a ventilator and you can't really hear what's going on. So pericardial disease, but really we're interested in pericardial effusion. But obviously with pericardial effusion, there's a difference between a clear pericardial effusion and then really fibrant stranding and I'll show you what it looks like when it's exudate. Okay, and then we want to do something about fluid assessment. Now, this is quite complex and there's no one view that you can do and give you an answer. It is context specific. What's wrong with your patient? Is this trauma? Is this sepsis? Is this cardiomyopathy? Is this calcium channel blocker overdose? All of these things you need to put together. But there's definitely some things that can help us with that assessment. Me and fluids. And when is enough fluids is enough? And this is where ultrasound can really help you just to figure out, is it really going to be useful and to give more fluids and why are you giving the fluids? What's your endpoint? Okay, so quickly, the parasternal long axis, so third or fourth, and just be aware that like COPD patients, hyperinflated patients, you need to really go much lower. Sometimes you need to be in the subxiphoid area to be able to get that parasternal long axis view. So the probe markers to the right shoulder, and this is what you see. So you see the RV at the top, you've got the aortic outflow, and then you've got the left atrium at the back. So those things should be a third, and a third. If they're out of whack, then there's something wrong, and you need to figure out which one it is. But you can see that now. You can see, look, that contractility looks really good. The valves look supple, and as soon as something is wrong with the valve, usually there's a lot of it's quite white, so it's easy to see then when there's something wrong with it. Okay, so parasternal short axis, you're cutting basically through the heart, and you just literally turn that probe to the left shoulder, and you fan through from a aortic valve. This is the mitral level, so just distal to the mitral valve, you get the papillary muscles, and that gives you a really nice view of the LV. Okay, so on that view, it's really easy to see what the contractility is like also. And then obviously, if it's not nice and round, then you need to figure out why is the LV not nice and round. So if there's a flattening of that septum over there, then that means that the RV's got pressure overload and it's pushing on the LV. So you need to think why that is. Did you give too much fluids? Is this a PE or is this chronic pulmonary hypertension from COPD or whatever? So that you need to figure out. Okay, apical four-chamber is probably the most difficult view, definitely in the critical care environment. Luckily, if the heart is really diseased, it's usually easy to see. So if it's a younger guy and you're really struggling, then it's probably because the heart is probably not too bad. But you got to hunt around for that apex. And I think the problems is like surgical emphysema is a problem. Chest drain's a problem. That tegaderm that you put over is a problem with your view. And that's why you can probably, it'd be unusual to get 4 brilliant views on all of the places you put your probe. But if you get 1 or 2 good views, that hopefully will give you the information that you need. Okay, so probe marker, and you need to find the apex. Probe marker is down to the bed. And this is the view that you're getting. Okay, so left is right and right. And you should be able to see all 4 chambers. Okay, subcostal view, then probe marker to the right, and this is the view that you get. So that's really good to look for pericardial effusions. But if someone's done a laparotomy, that view unfortunately is not available anymore. But yeah, usually even if you struggle, you can still see the IVC. Okay, we're quickly going to talk about vexes. Now, the idea behind this is now when is your patient getting edematous? So by the time that you find, gosh, the patient looks a lot different to what yesterday when, he was quite nice and thin and now it's edematous, everything's edematous by that time. Okay, so you probably don't need to think too hard that the kidneys are going to be edematous, the liver, the gut, the lungs, everything's going to be edematous. So they came up with this protocol that has actually been validated that if you use this protocol and you score even mildly, that there's an increased incidence of renal dysfunction. So it is quite useful, but I think I'll show you what it looks like. So basically step one is look at the IVC. If the IVC is more than 2 centimeters, proceed to step 2. Okay, if it's less than 2 centimeters, then you probably don't have significant congestion of your organs. So that's quite useful. Do you understand? So to be able to see, look, the IVC is less than 2 centimeters. Yes, fine. I can give some fluids if that's what you think you should do. And I wouldn't be too worried with the IVC less than 2 centimeters. But if the IVC is more than 2 centimeters, then there are 3 areas that you look for. And one is the hepatic vein. And I'm not going to go into the details. I can show you practically how to do it. It's actually not that difficult. The hepatic vein, you put a Doppler on the hepatic vein, and the hepatic vein is quite very easy to see on the ultrasound, and it's blue. So if you put your probe on the liver, because you remember that mnemonic BART, I don't know if you know the mnemonic, blue away, red towards. So it's flowing away from your probe, so it's blue. So you put a Doppler on it, and then you get this signal. You're going to get a wave like that. That's normal, then it's mildly abnormal, and this is severely abnormal. So it's quite easy to distinguish where the patient is. Now, the portal vein Doppler, that's normal, mildly abnormal, and severely abnormal. And then the renal vein Doppler that you do is actually also quite easy to do, provided you can find the kidneys, get a good view of the kidneys. And then we look at the venous side of the renal blood flow. So that's normal, that is abnormal, and that's severely abnormal. So it is quite a useful thing, I think, but I think practically you need to just think how much time you're going to spend and do it. But I think when you're asking the question about fluid assessment, how edematous my patient, can I give more fluids? This might be actually quite useful. Okay, DVT, we get caught out every now and then, especially when we put in lines and things like that. The DVT there. So that happens. You've got patients with casts on them. There's lots of reasons why people can develop a DVT in the ICU. So it's definitely worthwhile to think about it, especially when you've got a patient that you're trying to figure out why they're in shock. Then you can easily say, look, there's not a DVT. Obviously, P is a little bit more complicated. Okay. So it's actually quite easy to spot it. And luckily, you'd be super unlucky to have DVTs in both legs. So if you're unsure, go to the other leg. Just see what the normal side looks like, and then you can go back to the abnormal leg. So remember in the popliteal area, the popliteal vein is superficial and the popliteal artery behind that. And be careful, because if people do have DVTs or they've got incompetent venous system, then the superficial veins can actually be quite big. So you've got to find the popliteal artery to make sure it's popliteal vein, because sometimes the other veins can look like the popliteal vein. So lung ultrasound is different, and there's really a few things that can really help you with your questions that you got to your patient. So it's an artifact analysis, and I'm sure you've seen this picture. So this means that there's lung sliding. So in that area, there is no pneumothorax when you see that. And just take note that there's an A line there. So that is the pleural line. There's an A line, and that should repeat. It means that the underlying lung is normal. Okay, so you don't have a pneumothorax and the underlying lung is normal. So that is quite useful. Okay, so that's normal lung sliding. And then obviously if you have it absent, then it looks different. So this is what it looks like when there's absent lung sliding. You can see there's no lung sliding on that side, but that doesn't mean that there's a pneumothorax. Just remember that. It just means that there's absent lung sliding. There are different reasons for that. It could be pleural disease. It could be that the patient's really not breathing that much. So there are quite a few reasons for that. So don't just stick in the brain just because you see that. However, if you do see this, the lung point, then you know 100% there is a pneumothorax. Okay. But in the ICU environment, just think about it. Not every pneumothorax needs a chest drain. So sometimes, the patient's going to go to theater and you think like, oof, should you not put in a chest drain? I think I'm a little bit more comfortable, depending on what you do with your anesthetic, with having a pneumothorax there that doesn't need a chest drain. So it really depends on your anaesthetist. I think they will probably err towards always putting in a chest drain. No? Okay.
Us operating, we just have a little stuff ready there during the patient.
Okay.
And then if patients go home and we do it.
Yeah.
Or if it's inevitably the patient will be ours because of the pneumothorax. But if they're going for an auto-related procedure, then that we're aware of it and that's
Yeah. And also different, look, if the patient's breathing spontaneously on the anesthetic machine versus you're completely paralyzed because you're in the gut, you're in the abdomen, I think, you just got to put those things in context. Right, so that's why we see a lung point, is that at some point the lung is touching the chest wall. Okay, A lines we talked about. B lines. So what are the causes of B lines? So pulmonary edema. Okay, well, let's say consolidation. I'd say infection. Okay, yeah, what else? So what can cause fluid? Pulmonary edema. Okay. So all the viral stuff is going to give that to you. PJP is going to give that to you. So there's a lot of things that give you that. So then in that area there is interstitial fluid. Because you can scan around, now you can quantify and say, look, there's interstitial fluid there's everywhere. Then you know that is pulmonary edema, be it cardiac or non-cardiac causes. So you mean you want to explain why it makes those lines? Yeah. So B lines are those white. If we just go back to, so for instance right. So A lines cut across this way. Okay. There's no lines running down, white lines lying down. And on this picture, 2 or more in a sector, so this would be a sector, is abnormal, and they run all the way from the top all the way to your ultrasound field.
It's not spot.
Yeah. If there's just a small little stripe down there, it's called C lines, and those are actually called comatal artifacts. So then you can see them if you're a little bit closer. But if they go all the way down, those are B lines. Okay. Now, if you think about your patient, B lines aren't that uncommon, even when they don't really have significant pathology. It's like the bases, the dependent part. So usually there's a little bit more interstitial fluid than it would be at the apices. But if you've got B lines everywhere, then that gives you information versus B lines just on one side. Then you've got to think infection rather than pulmonary edema. There's something called the blue protocol. I don't want to go into the blue protocol. That helps you from a lung ultrasound point of view, figure out what's wrong with your patient. Why is your patient short of breath?
It's on that POC app.
POC 101. Yeah. Okay. So pleural fluid. So this is obviously an organ, be it the spleen or the liver, and then that's pleural fluid, and you've got the lung there. So that also, if you think about it, your trauma patient, if there's pleural fluid there from trauma, whether now has an X-ray or not, he needs a chest drain because there's blood in there that needs to come out. So that helps with that. Then you can rather just get the X-ray afterwards. Okay, so vascular access. Now look, all I can say is please use the ultrasound, okay? And get comfortable with using it. Use it more often than this one patient that this is a difficult patient, I want to use it. I don't mind helping people, but also you need to get to a point where you feel comfortable doing all the lines, because you're going to be putting in lines for a long time still, I think. So just the two approaches. Remember, there's the in-plane. Now, we don't use it that often. Sometimes it's difficult in the neck, especially when it's a short neck. But it can help you sometimes when you can't figure out, because, I do a lot of pediatric lines also. Sometimes you really can't figure out why on earth this wire's not going in. And then sometimes the in-plane can help you. It's technically, a little bit easier. Well, I think the difficulty is just getting your plane right and getting your needle so that you can see it. So it takes a bit of practice. Then the out of plane is probably, I think, what most of you are using. And the idea with the out of plane is that you have your probe and you have your needle and you do the stepwise approach where the needle goes in until you see the tip. Then you move the probe forward, needle forward, probe forward, needle. And you do that stepwise approach until you're in the vessel. Because if you just have it there and you stick past, you think, oh, you're poking around and it looks on the screen like there's just something there, but your tip of your needle is way down there and you don't know it. So that's what I'd suggest you do. Don't just stick the needle in and kind of poke around there. So that's the out of plane. So you can use a combination, obviously, of both. But my tips, okay, just figure out where on earth your needle tip is. I think I see so many people just going past and then the needle's all the way in. And, then you don't know when you're in, when you're out, when you hit the lung, especially if you're in the neck, So I think that you should be able to follow your needle tip. Right? You know that transducer, non-dominant, hand carrying and dominant. Look, if you're doing a central line, that's long enough. But with if you do like a peripheral line, I must be honest, if you're not doing on the superficial veins, like I've tried to use a green on like the deeper veins, they come out. They're just not long enough. So I wouldn't put that in like if you're going into the deeper tissues. So one thing that I see people do is also their non-dominant hand is just loose. So as soon as they look at the screen, the hand starts floating and then floats this way and then you're like, oh my word, what's going on? You need to put that hand down. You need to put your finger somewhere that's stable and that shouldn't move. Otherwise you're just drifting off the whole time. Different sizes and the confirmed placement, I can't stress this enough because, Bianca, every year or somewhere there's a line that someone places in the artery. Okay. And once you've dilated, it's too late. Okay. And there should be no excuse to confirm that it's in. Okay. So to confirm it, before you dilate, once you've got the wire in, then you take the probe again and you look and see, is it in the vein or is it in the artery? Okay. Here's a few slides of how to do it. So this one at the top, that's great. I can see, fantastic. There's my wire going all the way through. This is probably the one I think I encourage people to use the most. This is that fanning technique. And you can see there's the line going from there going down. This is looking at the IVC, and then you can see the tip of the line sitting in the IVC. This one is agitated saline. So you can just take saline in a syringe, pop it in the subxiphoid and just pop it in, and it will look like that. Then look, I'm not in the artery. So I can't stress this enough. Please make sure your lines you're in the vein.
But then it's too late. I mean,
this one?
Yeah.
What do you mean you're too late? This is true. Yeah. No, this is true. That's why wire is the way to go. Before you dilate, check again. You've got the ultrasound. Make sure you're in the vein. This, that's not going to help. I mean, whether you put it in the femoral or once you put saline in, it's going to go up to the RV. So that doesn't help you. No. So whether it will just tell you it's in the venous system, not in the arterial system. But the goal is really here with a wire. Check the wire and see where the wire is. Yeah.
You follow the wire.
Yeah, look, it's not always that easy with the pacemaker because the pacemaker, the wire, we normally put it in the internal jugular. So then I will usually look sub-xiphoid and just see, there's the wire sitting in the atrium, blah, blah, blah. Because you need to float the catheter up to the RV. So oftentimes you can see that it's not in the RV. You need to come back, push it forward. So it really helps because we don't really have a C, well, we have a C arm. We're not going to use that, but yeah.
If you're a favorite lead, then you can follow it up to the IDC.
Yeah. It doesn't, you still need to, once it hits the right atrium, you still need to get it in the RV. So you've still got to come around the corner. And so I think it's probably easier to put it in the internal jugular, where you've got more chance to get it in the RV. Okay. Right. Just a few other things, that I think is really useful. Okay. Ilham, what is that? Okay, so that's bowel. Okay, so small bowel. And if you see small bowel, now this question versus ileus versus bowel obstruction, or, what's going on, just put the probe on, because if it's ileus, it's going to be static, right? The bowel is not going to do peristalsis. It's going to be static. So then you know how to diagnose ileus. It's not with a stethoscope. Okay. I know you guys still have stethoscopes. Okay, and then bowel obstruction. Well, we've got one. We're nice. We will borrow it. We will lend it to you guys. And with bowel obstruction, you will see that there's lots of peristalsis, and the content is going through the loops and then coming down back again. So it's constantly doing this seesaw type of picture. Then there's bowel obstruction because it's not moving through. Despite the peristalsis, if there's peristalsis, it should be moving forward. So bowel obstruction is actually quite easy to see, especially small bowel, because there's fluid in it. There's no air in it. No. So normally the small bowel obstruction, there's just fluid in it. Okay. If you've got large bowel obstruction, then of the time there's air in it, and that might obscure it. But usually small bowel obstruction, if you hunt around, you're going to find it somewhere. I mean, the colon isn't sitting right across it always. So it's actually quite useful if you want to know about that. So we talked about absent lung sliding. So just quickly, kidney sizes is not difficult. If you can see the kidney, so that question, chronic versus acute, I know maybe you're not that worried about kidney sizes, but if it's an internal medicine patient, it does make a difference if you have a patient with renal failure and goodness, the kidneys are small, so they've got underlying chronic renal disease, yeah? This is true. Okay. Unless, unfortunately, the ultrasound's not going to tell you the creatinine. It's close. You can make an estimation. Yeah. So that is a useful question, isn't it? Yeah. Okay. So we talked about B-line, so we didn't go through that. So just looking at that heart. So the questions that we want to answer is, Janelle, what do you think of the contractility?
It's quite poor.
So you can say this is poor contractility. You don't need to say it's mild or moderate. You don't just say the EF is 30. But if you see a heart like that, that really puts things in perspective. You can see that the valves, or especially the mitral valve, is not opening as it should. And that's called a functional. There's going to be an MR, and this is a functional one. So the valve is not diseased just because it's dilated. Sorry, there were two slides missing. I'll just tell you what was in there. Okay, so this is I think it's the left upper quadrant. Yeah. Okay, I'm sure some of you have seen this. Okay, that little thingy moving up or down, that is consolidation. There's nothing else that gives that to you. That means that you can actually see the lung tissue, but there's still air flowing into it. If there's atelectasis, there's no air flowing into it. Okay, so when you see that thing, it's actually a bubble sitting in the bronchioles, moving up and down with respiration. If you see that doesn't matter what it looks like. spastic pneumonia. There's nothing else that gives you this little thing. And we've had a patient, that we've seen that. Then there's consolidation. Now, not all consolidation is infective. Just keep that in mind. It could be other things, but at least there's consolidation. Okay, so this is probably a little bit more subtle, but if you're thinking about free fluid, there at the top, you can definitely see some free fluid. So when you're hunting around for free fluid, obviously we teach the four quadrants, but just hunt around a little bit and you'll be able to see free fluid in between the bowel loops. Yeah. Ilham, what do you think?
Well, no.
Yeah, you got to tell me. We're in the body.
Human.
Okay, so there's a clue here that there's a shadow. So it's a solid thing. Okay. So the stuff that makes a dark shadow means that the ultrasound's not getting through it. Okay. So these are significant gallstones sitting in the gallbladder. Okay. So then your pancreatitis patient, this is useful information. Okay. Is there gallstones, yes or no? What's the cause of the pancreas? Was he drinking or does he have gallstones? So those are the two most common causes. And also, what does the gallbladder look like? Is it really inflamed? Is it angry? Or is it normal? That is useful information. Okay, so this is the kidney. And, I put this, so this does catch you out every now and then. I remember there was this really septic patient that was treated for GI. I remember ST. Strip.
Wow.
Yeah. So she was treated for septic shock, from GI origin. And I can't remember if I ultrasounded her, but she went to Cape Town and they CT'd her and she had hydronephrosis. So she ended up with a stone with hydronephrosis, secondary infection, and that's why she was septic. So septicemia. Yeah. Yeah. So again, hydronephrosis is quite easy to see. And the one thing is also, the cortex of the kidney there looks normal. Obviously, I know because I look at a lot of kidneys, but there's no cortical thinning. So this is going to be acute versus something like this where you can see the cortex is thin. So this has been long-standing. I can't quantify, probably 6 months to a year. So that is different. And then yeah. But, obviously there's a severe hydronephrosis plus there's cortical thinning, which means this long-standing. You're not going to reverse this kidney function by quickly putting in a stent. This is long-standing versus this patient. You think, well, this is acute. There's no cortical thinning there. So there is value maybe in decompressing that.
So what does a normal...
The ratio?
Well, no, I'm talking about the pelvis. So is there a measurement or is just...
So for hydronephrosis, so you're talking about mild, moderate or severe hydronephrosis?
Yeah. Do you have a...
So mild hydronephrosis, the ureter is still normal, but the calyces, remember they do this, they start doing that. Okay, so that's mild. And then moderate, you get more dilatation with less than 1 centimeter dilatation of your proximal ureter. And then if it's more than 1 centimeter, your proximal ureter, then it's severe hydronephrosis. But obviously at that point, you're also going to have the calyx is much more prominent. So we talked about that. So this is the eye. So maybe it's not that useful for us because we CT patients, but so this is how to look for raised intracranial pressure. Obviously we just do it once, the CT scan. It's not something we repeat within 24 hours oftentimes. So this, I don't know, maybe it's not helpful for us, but I think if you're in Beaufort or you're somewhere else, you're not sure, is this guy just drunk, was there really something else, and you do find that it's abnormal, then that really raises your suspicion. So it's 5 millimeters down, I think. So 3 millimeters down from your retina, and then you measure across your optic nerve. And if it's more than, so the various 5 millimeters or 6 millimeters, certainly above 6 millimeters, that is abnormal. And you've got 2 eyes. Okay. So scan both of them because there might be a local cause for that optic nerve to be dilated. Okay. So this is quite useful because this is a lung. So when you see that, you don't need to send off lights criteria. This is an exudate. Okay. There's fibrin stranding everywhere. So now whether this is TB or some other exudative cause, that doesn't matter. But we don't need a albumin and a lights criteria to figure out if this is an exudate. Okay. Okay, so that's a thrombus dancing around there in the vein. The other day we had a patient with a large thrombus swirling around in an RV. So, then you don't need any further investigations. This patient has got a PE. Okay, sorry, this is not for critical care, but this is a molar pregnancy. This is a lens dislocation. So lenses are quite easy to see. Sorry, this is not critical care. Actually, I think I lost a few slides, or I deleted a few slides. So this is pleural fluid, and when you see this, those things floating around there, it is because of high cellular content. Okay, and it's definitely going to be an exudate. It is sometimes difficult to know whether this is empyema or not, but when you see that it's an exudate, you need to put in a needle anyway. So put in a needle, and it's going to most likely going to be probably an empyema. Okay, but this is the retinal detachment. And then papilledema, this is more for the physicians. I think we're not really going to look for papilledema, but look, I don't know when last you looked into the eye. Yeah. But I mean to know whether there's, to know whether there's papilledema or not. I don't know, Bianca. Maybe it's just me. So ultrasound. Yeah. So ultrasound, you can see the papilledema. Right, so there's also retinal detachment. You can see the retina moving around in the eye. And then, so this is one of those bad hearts. So what's wrong with that heart? Yeah, so the contractility is bad, yeah. Okay, what is wrong with the outflow tract? Yeah. Yeah, so you can see literally that aortic valve is opening. So this is aortic stenosis. And I think that's all you need to know. This is aortic stenosis. Now, whether it's mild, moderate, or severe, that I don't think you need to figure out. But when you see that, right, so this is severe. Well, it's going to be severe aortic stenosis without doing any measurements. And you see how easy that is to spot. When you have nice, supple valves, that's sometimes difficult to see, but that's quite obvious. Okay, pericardiocentesis. I don't know if you've done it with me. So procedures, I think it's important, ultrasound. And so we look and see where the effusion is the most prominent and then do the ultrasound there with a needle. We don't go blindly just in the subxiphoid. Same goes for pleurodesis. Use the ultrasound because I do not like it when people say to me, I've stuck in a needle and nothing came back. Did you use the ultrasound? Okay. So please use the ultrasound. Fracture reduction, you don't have to worry too much. It's not critical care. So there were a few slides. I don't know how this happened. Sorry. There's one other condition that I want just to highlight. It's called SAM. So SAM is systolic excursion of the mitral valve. So the mitral valve sits, maybe I'm just go back to one of the, so the mitral valve, the anterior leaflet flaps up in diastole. So that's when you get left ventricular filling. So when you've got a really hyperdynamic heart, the mitral valve flaps up, and as the heart contracts, it pushes the mitral valve into the outflow tract. So then you get obstruction. So they actually get left ventricular outflow obstruction. So normally we see this with hypertrophic cardiomyopathies, but in the critical care environment, you see this also. And we don't often look for it. So patients that are prone to getting there, or that you should be, the ratio of suspicion are patients that are have got escalating doses of adrenaline with no effect. I must just maybe just see if I've got the lecture, because I did put that on. Apologies.
You don't have maybe pictures of bees, like
of the RV? No. No.
Does the leaflet flat out and get stuck and stays?
So it doesn't get stuck there. It's about how long it stays in the left ventricular outflow tract. So as it pushes, it's going to push it, but then it does come down again. At the end of systole, it will come down again, but it does cause outflow obstruction. Let me just quickly see. Sorry. Sorry? So oftentimes they do have a regurg, but they don't need to have it. So it can be just a septic patient, with so it is just they're going to have probably a bit of hypertrophy. It's not going to be completely normal heart. And it's usually in the context of hyperdynamic heart. So patients are really, really tachycardic, so that the mitral valve flaps up and it's never been masked. The sepsis will unmask it. So then it flaps up and then you get that left ventricular outflow tract obstruction. So the way to think about it is, if you've got escalating doses of inotropes in a really tachycardic patient, and you don't know why this patient is doing that, is then to check for SAM. Because the treatment for that is, it could be that the patient needs more fluid, and he needs more inotropy, and you need to control the tachycardia. Now, if the tachycardia is driven by your adrenaline, then that might, by the time you think, well, let me switch to phenylephrine so I can just control the tachycardia. There are some people that suggest that you should use a beta blocker, but that will be in the context of esmolol or something like that. It's a short-acting one. We unfortunately don't have short-acting, so I'm definitely not going to give a beta blocker in such a patient. But that is what people suggest sometimes. So it's just something to maybe just be aware of and think about. Why are the adrenaline requirements going up on this patient, and it's just getting worse the more adrenaline I give? It might be that there's a SAM.